My name is Keaton, and today I'll be presenting my thesis topic named The Automatic Segmentation of Coronary Arteries Substructures in Searching for PET and CT images using convolutional neural networks. I'd like to give thanks to both of my supervisors, Martin and Pejman, both of whom are here today, and supported me in the entire 12-month journey. So before I jump into the technicals of the deep learning approach, I'd like to give a brief summary of the significance driving the research. And for that, we have to delve into the prevalence of cardiovascular disease in the world. So this here is a breakdown of the top 10 causes of death in Australia in 2019. As you can see, ischemic heart disease takes the top spot, unfortunately. 11%, nearly or over 18,000 people died due to ischemic heart disease in 2019 alone. And in fact, the prognosis for those who survive an initial cardiovascular event is actually quite poor, with 30% either being rehospitalized or dying in the following 3 years. And so how do we actually assess a patient's risk? What diagnostic tools are available to us? Well, primarily the standard metric is the coronary artery calcium score, and through various multi-ethnic cohort studies has shown to be strongly correlated with the incidence of CVDs. And this is quantified via calcium score CT scan. A more novel new approach is the sodium chloride PET scan, which has shown great promise in identifying microcalcifications, something the CT scan cannot ordinarily resolve. And these are quite characteristic of ongoing mineralization, so patients who are actively getting worse and are unstable. So both of these provide mutually exclusive, useful diagnostic information, which is important because there are not many effective treatment methods available to us. So what exactly is segmentation? Well, broadly put, it is the partitioning of inputs into coherent regions based on their shared anatomical or functional characteristics. So we have a sample CT axial slice there with 3 pertinent contour sequences named as. So how are these useful? Well, a variety of applications. For instance, they may be used to derive clinical metrics, such as the ejection fraction, myocardial mass, or the wall thickness. And this is obviously in the context of cardiac segmentation. Alternatively, they may be incorporated into 3D or time motion analysis, which pairs quite well with adaptive radiotherapy and other surgical applications. And of course, with reference to the previous slide, they're used in the diagnosis of CVDs, so CAC quantification or stenosis grading. Which leads quite nicely into the significance and aims of the project. Simply put, manual segmentation as performed by a clinician is a very time-consuming endeavor and prone to significant inter- and intra-observer variability. And that's by merit of the fact that it's performed by people, and people unfortunately suffer from fatigue, observer bias, and the environmental conditions are often different, such as the lighting. So development of a clinically acceptable automated segmentation algorithm would offer improved reproducibility. Once these deep learning models are trained, they are entirely deterministic in their outputs, so they'll reproduce the exact same thing. And there are massive efficiency gains, obviously. So the model might predict a scan segmentation in seconds, as opposed to minutes or hours for a manual delineator. And this frees up extensive hospital resources, which could be reinvested elsewhere into the clinical workflow, such as possibly increasing patient care or the quality, or simply the hospital capacity. So the actual project aims, well, were in generating automatic segmentations on a bunch of salient cardiac structures, and that was using exclusively CT data, but then also CT PET fusion data. Secondly, was comparing these results by subbing in a variety of pure and compound loss functions, using region overlap and boundary distance metrics to grade their performance. And I'll go into what each of those terms mean during the methods. And thirdly was in conducting an inter-observer variability study to assess the reproducibility and efficiency of the automated models. So as you might suspect, there's actually no shortage of deep learning cardiac literature, which is useful in that it provides many useful benchmarks for me to compare the results of my own models, but also guided much of the research directions I took during the experimental phase. For instance, this first study by Morris et al. In 2019, they used a 3D adaptation of the UNET architecture, which was conceived by Ronneberger et al. And is considered to be the gold standard of biomedical segmentation. They achieved quite high DICE scores of 0.88 on a variety of cardiac substructures. So that was the benchmark I was aiming to match in my experimentation. Just for reference, a Dye score of 1 is perfect overlap. Secondly, this study by Young et al. In 2018, they used their own uniquely designed fully convolutional network. Importantly, they used a hybrid loss function, combining both weighted dice loss and weighted cross-entropy loss. I'll go into what each of those mean. But importantly, what they found is that they achieved superior results to loss functions that were trained on their own. And that inspired much of the research I did into different loss function combinations. And finally, in this directly applicable study by Puri et al. Very recently in 2021, they had an identical modality combination of sodium fluoride PET and CT, and they used a UNet architecture variant to compare automatic and manual segmentations. The conclusions of which they found was that the automatic models supplied roughly equivalent SUV radiomic measures in their segmentations, indicating clinical acceptable standards, but only in a fraction of the time, which speaks to the efficiency. So what was the data set I was using? Well, it comprised of 149 patients who participated in the VicaVac trial. That's the effects of vitamin K and colchicine on vascular calcification. They received their PET and CT scans quite close at Royal Perth Hospital at both baseline and follow-up, with follow-up being 3 months apart. The manual co-registration and delineation was performed by a skilled clinician on 3mm spaced axial slices, and there were 2 primary studies, the coronary arteries on the gated scan and the aortic substructures on the ungated. Now, the inclusion criteria for this study were sufferers of type 1 or 2 diabetes, aged 50 to 80, and who scored above 10 Agatston units on a preliminary CT screen, and that's for their CAC score. And that obviously indicates some calcification present. So those 2 studies I mentioned before, the first of which is the aortic substructures. Here there were 4 pertinent contour sequences we were looking to automate, the ascending, arch, descending, and the cardiac silhouette sequences, and you can see them drawn here. One thing you might notice is that the purple region, the cardiac silhouette, completely eclipses the ascending aorta, which means if the model were to attempt to predict, say, a pixel sitting inside that yellow region, it would effectively have to provide 2 labels because it sits inside both those contours. Now, the model I trained lacked this multi-label functionality, which required me to break up these sequences into 2 groups, the first of which had all mutually exclusive contour sequences. The second study was the coronary artery study, which had 6 pertinent contour sequences ranging from the circumflex artery to the right coronary artery. Now, these were luckily all mutually exclusive, no overlap, which allowed me to pair them together into a single contour group. One change I did make was in combining the LMC and the 2 left anterior descending contour sequences, and that was as a variance reduction measure, as these sequences very infrequently appeared on the scan on only a few slices, and they were incredibly small. So the model had quite a lot of difficulty in differentiating and locating them. With the data partitioning, well, those 144 patients produced respectively 297 co-registered PET-CT scans for the aorta study and 140 co-registered PET-CT scans for the coronary artery study. And that's by merit of the fact that there were CT scans conducted at baseline and follow-up for the top, but only at baseline for the bottom. These were subsequently broken down into training, validation, and testing sets, with 20% of the entire set going to testing, and that's the independent test used at the very end once the model has been trained. And then on the remaining 80, 20% of that was given to the validation set, which evaluates the model during training. The training set is the data which is passed through the model and used to update the parameters. That leaves me, what was the model? Well, very broadly speaking, it was a convolutional neural network. I won't delve too deeply into this, but it functions by isolating and extracting features by repeat application of convolution and pooling operators. Broadly speaking, a convolution operator is sort of synonymous with a filter. So at a very low level, it might extract horizontal and vertical lines from your input image. And a pooling operator is a standard downsampling operator, learning to condense the features into a smaller representation, only keeping the most important ones. And obviously, as you go further down into the network, the convolutional filters extract more relevant features. The exact type was a fully convolutional network, which is used for semantic segmentation, the problem I was dealing with, in that it assigns predictions at the pixel level. So in other words, every single pixel in the input is mapped to a corresponding pixel in the output with the same dimensions, either saying, yes, there is something here, pixel value 1, or no, there is not something here. And that ends up with a segmentation map like that. The exact architecture I used was based on the UNet architecture, which I mentioned previously, and that combines a reflected downsampling and upsampling path, which respectively extract the features and condensing the representation down here, and then use transpose convolutions with learnable parameters to expand these features into the output map you see there. And you'll see these horizontal feature channels, which were there to propagate contextual information to bypass the lower layers, and that aids in improving localization. So you've probably heard the word NNUNet from Jake or myself in the Wednesday meetings. That's the exact model I used. But to understand the problem or the design choices of NNUNet, you first need to understand the problem it is trying to address. Now, as I mentioned before, when you dive into the deep learning literature, you'll see there's pretty universal success of deep learning automated models for segmentation. However, what's often omitted from these studies is the poor generalizability of these models on very slightly modified data sets. So hospitals obviously have a range of scanning modalities at their disposal, such as CT or MRI, and they respectively have a variety of image settings, such as voxel spacing. And these small changes, whilst seemingly insignificant on their own, add up to have a dramatic effect on the exact choice of model hyperparameters and the optimal choice of hyperparameters, which means researchers are required to subject their models to pretty extensive testing, such as grid searches, to find this optimal configuration. And this is further exacerbated by the cost and difficulty in procuring medical data sets, often limited by ethical or labor constraints. So efforts to try reduce all of this hyperparameter search space, improve generalizability, and generally make deep learning more accessible to people who don't have infinite computing resources. That field is known as AutoML. So NNUNet implements these principles by standardizing its approach to much of the pre-processing and training pipeline. And to do so, it starts off by extracting what's called the dataset fingerprint, comprised of all of the metadata of the input images. And it uses this to drive its design choices, such as the network architecture, which is originally based on UNet, but then dynamically changes the number of layers to ensure that the feature map dimensions down the bottom are at max 8 pixels in either direction. It handles most of the pre-processing, so the cropping, resampling, or normalization of the images. It also implements a number of data augmentation protocols, such as random scaling, rotation, or elastic deformation, the last of which is especially useful in simulating natural tissue variants that you would see in images. And finally, the training protocol it uses is a DICE cross-entropy compound loss function. So on the note of loss functions, we have to first, where do these come from? Well, these are mostly derived from evaluation metrics. So just briefly, you might hear accuracy is quite a common metric to be used in machine learning. This is actually very unsuited to segmentation problems which feature a large class imbalance, i.e. where the background is much bigger than the foreground. So say, for instance, we were trying to predict this right coronary artery segmentation. This would be the ideal output. But alternatively, if the model predicted a purely empty screen, it could still achieve 99% accuracy. Clearly, that's not helpful at all. So since there are multiple types of segmentation error, we actually have to use multiple metrics, each designed specifically towards segmentation. So the first few which I used are the specificity and the sensitivity, which respectively give the percentage of background and foreground pixels correctly identified. And these have to be used in tandem with each other. Alternatively, the DICE similarity coefficient, which incorporates all of this information and handles class imbalance quite well, it measures the overlap between the ground truth and the prediction foreground region. And that ranges from 0 to 1, with 1 implying perfect overlap. Now, these two metrics, whilst quite effective, fail to take into account the actual boundaries of the segmentation, which obviously is quite important in a medical context. And that's why I also use the two surface distance metrics, mean absolute surface distance, which calculates the average minimum distance, and the Hausdorff distance, which calculates the maximum distance between the two surfaces. Now, the latter is obviously very susceptible to outliers, so shouldn't be used on its own, as I discovered in the results section. So from these, we can generate a number of loss functions, which I subbed into the models, and these are broadly categorized into three, the distribution-based, region-based, and boundary-based. As we see here, the dice loss and the HD binary loss are essentially the analogs of the evaluation metric I described previously. And there's cross-entropy loss, which is also quite valuable. Now, the region and distribution losses also include Tversky, focal, and top K10, which aim at tackling the class and balance problem by adding a number of modulating factors which discount certain types of error. From these, we can generate a bunch of compound loss functions which integrate these together, trying to cover the inadequacies of certain evaluation metrics. And then also we have quite a few here. So these 10 loss functions are all the functions I used in my testing for the experimental phase. So this big table here is all 60 models that I trained for my testing phase. So on the left, you see the 10 loss functions I implemented. And on the top, you see the 3 contour groups, which correspond to the 3 models. Now, for each of these combinations, it was either trained exclusively on CT data or PET-CT. Furthermore, the models were trained with 100 epochs with training times ranging from 2 to 10 hours. So a lot of stuff to compare. So finally, we can look at the actual segmentation results. So this mammoth table essentially summarizes all the results for the aortic substructure study trained exclusively on CT data alone. Now, there are 3 other such tables corresponding to the PET-CT and the 2 combinations for the coronary artery studies. Now, these metrics are calculated on the testing set, firstly on a full patient scan basis, and then averaged over the entire testing set. You have the 10 loss functions and the 5 metrics I was using to quantify. Now, clearly, there is far too much data to go through. However, what I did find is that there are a number of patterns which were consistent throughout all 4 tables, which I would like to address. The first of which is the consistently high performance of the DICE compound loss functions compared to their respective pure function counterparts. So we saw some pretty marginal increases in the DICE scores, however, some notable improvements in the Hausdorff and the mean absolute squared distance. The biggest improvement, however, was in the variance. You can see here in the Hausdorff, it was consistently 2 to 3 times smaller than the pure DICE loss functions, which implies far more consistent results. Furthermore, the introduction of top K10, briefly top K10 examines only the top 10% of error contributing pixels and disregarding those which don't contribute particularly much to the error. So it focuses primarily on outliers. I found that introduction of top K10 improved results on all of the equivalent functions which didn't use top K10. So for instance, DICE cross entropy versus DICE cross entropy top K10, the top K10 variant performed better in all the metrics, and that was consistent with all the models. The second of which is the consistently lower performance of the distant metric loss functions. You can see here the DICE, Hausdorff, and mean absolute squared distance are massively worse than the DICE compound loss equivalents. However, you might notice that the introduction of DICE does improve the metrics for all cases. So that might suggest there is perhaps a middle ground between pure HD binary and pure DICE loss, which perfectly integrates those 2, which I would like to explore. Now, the reason for that low performance, as I discovered, was because Hausdorff distance is especially susceptible to outliers, hence limiting its use in early training, where you would expect predictions to be bad and outliers to be everywhere. However, it is one particular application of Hausdorff distance is in fine-tuning an already high-performing model. So something that could be done in future is training exclusively on DICE loss, and then once the model reaches a high standard of performance, fine-tuning with the Hausdorff loss function with a couple more epochs. But what that tells me is that a few more nonlinear combinations of these compound loss functions should be tested. There's more than one way to combine these loss functions, in other words. So this is a head-to-head of the top-performing aortic substructure models from the CT and the PET-CT. We have the DICE top K10 focal and the DICE top K10 cross-entropy. You can see that the PET equivalent, or the addition of the PET channel, improved the performance in all metrics. However, it must be said that these are only very marginal improvements, and so if the only purpose of introducing the PET data was for this, it might not be consistent with LARA principles. However, that is not the best use of the PET data. In fact, I would like to explore how the PET data may be used for diagnostic testing. In other words, combining the segmentations to see how they might be used to predict patient risk factors for cardiovascular disease. You can also see that the introduction of PET data, comparing the left and the right, shows a reduction in outliers. So there are fewer dots exceeding outside the interquartile range. Each dot corresponds to a single patient scan, and the box is the interquartile range, and the lines are generally the range of the data. So introduction of PET data reduced the variability somewhat. Now this is by actually printing out the predictions, I was able to see where the aorta studies suffered. So what I've got here is 9 sequential axial slices with the CT scans superimposed on the segmentations, right? A quick description: red corresponds to where the model predicted something. Green is where the clinician outlined something, so you won't see much of that there. And yellow is the overlap. So in other words, the more yellow, the better. As you can see on these 7 slices here, there is very high clinical accuracy of the segmentations. However, we see these 2 slices here in which the model is predicting something that the clinician did not. In other words, the model is overestimating the segmentation endpoint, the endpoint being the axial slices on which the clinician begins and ceases their segmentations. So this is not necessarily a bad thing. Despite tanking the evaluation metrics somewhat, it's a lot easier for the clinician to just go through, examine these, and delete the contours. Obviously, that does mean the model is not completely automatic, but it's a step in the right direction. And these 7 slices do demonstrate its high clinical applicability. Now, this is the top performing models for the coronary artery study for the CT and the PET CT. So we had the DICE top K10 cross entropy and the DICE top K10. And I've got similar box plots for the DICE sensitivity, specificity, Hausdorff, and the mean absolute squared distance. If you look at the head-to-head comparison of the 2 models, you'll see that it's pretty back and forth. So introduction of PET data did provide improvements on the distant metrics, but it performed worse on the DICE similarity coefficient, which says that the PET data is complementary with respect to the approximating the boundary, but actually deconstructive with the DICE similarity coefficient. Then again, these differences are very small, so it could just be variation in the random initialization of the model. Again, however, we do see a reduction in the variance, so there's fewer outliers in the distant metrics, as you can see here. There's fewer dots outside the limits. So that suggests the PET data is providing complementary information to reduce variance in predictions. Again, this is me printing out a couple of axial slices for a given coronary model. The same format, so green corresponds to ground truth. You can now see the green here, and yellow is overlap. So in other words, on these 2 bottom slices, the model was able to successfully predict the circumflex artery. However, up top here, it failed to identify something that the clinician did. So this is the opposite problem to the aorta model, where the model is underestimating the segmentation endpoints. And that's obviously a greater issue than overestimating, because that means the clinician actually has to go through and draw those out. So that was responsible in turn for reducing the segmentation accuracy. Generally, both studies reached the literature benchmarks, so around 0.88 for the cardiac substructures, and general consensus is for coronary arteries, it is around 0.67, which, as I mentioned, reached roughly. So that takes us to the Interobserver study. So what I've got here is the study consisted of the clinician performing the exact same contours on 10 of the patient scans taken from the test set with the original contours hidden. And both of these were compared to all of these were compared to the segmentations completed by the clinician at the first time point. And what I've also done is I've compared it to the best models comparisons also to the clinician's first time point. What you'll notice is that it's pretty back and forth as to which one better or whether the model or the clinician better approximated the original segmentations. In fact, the model actually better approximated the boundary and the sensitivity of the original contours compared to the clinician. And you see similar results here in the coronary artery study. So what that tells us is that in many of the categories, the model was actually better equipped to predict the clinician's first segmentations than even the same clinician themselves at the second time point. Furthermore, there were significant efficiency gains in the study. So the manual segmentations by the clinician took between 4 and 6.5 minutes. For the model, it took between 10 and 15 seconds for a full patient scan. So it's 25 times quicker. Furthermore, there was the deep learning models are entirely deterministic, so the predictions they output either today or 3 months later would be identical, whereas the clinician had a significant drop in reproducibility, which speaks to the superiority of the deep learning models in this metric alone. Now, it must be said that despite the models better approximated the first time point segmentations, this does not necessarily mean they are clinically viable. The clinician would still have to go through and verify that they are adequately matching the segmentations that they need to. In other words, the segmentation metrics are not perfect in telling you the success of the model. So what sort of future work can we address? Well, firstly, let's look at what we managed to prove. Well, the literature benchmarks on the aorta study and the coronaries were matched, which was a good sign. The NNUNet AutoML principles were proven to be successful, which goes to speak about the success of AutoML in streamlining much of the training and testing process, meaning it's more accessible to the wider audience. And there was also, however, some additional loss function experimentation. A lot of the loss functions were naively joined together, and so it might be interesting to test out different combinations. And like I said, see if we can transition with the DICE HD to first train on DICE and optimize with house walk distance. And finally, it might be good to introduce more clinical observers, as it's not good to use a single clinician's example as the ground truth. And also we can do an interobservability study. And finally, the segmentation results could be used for cardiovascular disease risk assessment. However, for that, I'll need follow-up patient information such as incident rates of cardiovascular disease. So thank you very much for listening. I'd like to give a quick thank to both of my supervisors, Martin and Pejman, who were instrumental in guiding me and sorting out much of the ethical and just securing the data in general. Of course, Jamie Bellinge, who performed the segmentations, who spent dozens of hours completing those, and Jake and Matt and the rest of the machine learning cluster, who worked with me alongside me for much of my project. Thank you very much. And these are my references.
That's great. Thanks very much, Keaton. Brilliant presentation. That's great. So questions from Keaton.
Yeah, I can
Very
see
high standard presentation, Keaton. Yes. So yes, Warwick, you can ask a question.
Excellent presentation there, Keaton. Thanks very much for that. I think you actually did touch on it in future work, if you don't mind going back to that slide. Are you able to?
Oh, yeah, of course. Sorry.
I wasn't sure you'd be able to hear me.
Is that, can you see that now?
It has not updated, sorry.
Okay, let me reshare.
Thanks.
But yeah, the question that I had was, what kind of quality assurance procedures or concepts that you could think of would you recommend in I guess, using a model like this, like clinically?
Is that to assess whether it could be implemented clinically? Is that what you're?
Yeah. So I'd imagine that you would need a degree of quality assurance in order to make sure.
For sure.
And I was hoping you might be able to, I mean, I'm sure you've thought about it. So.
Yeah, absolutely. So obviously these models are still a long way off being purely automated in a clinical setting. And plus I mentioned that the segmentation metrics alone are not, I guess, telling the full story. So it would be worthwhile taking the time to show these, I guess, segmentations to a trained clinician who can actually assess whether they do meet the benchmarks that are necessary to be implemented. However, it is still, I guess, necessary for clinicians to go through and verify that the standard of these segmentations are matching, I guess, the standards you'd expect in a hospital setting. So ideally, the segmentation evaluation metrics alone are not sufficient to assess whether they are clinically viable. You would actually need a clinician to go through.
Is there a quantitative way of assessing, or not really?
I suppose, yeah, there aren't segmentation metrics, but again, not that I'm aware of. I think best case, you would just expose them to a variety of clinicians, see if you can average out any biases they do possess, and see if they assess them as either clinically acceptable or not. I'm not currently aware if there is a single universal metric to say this is acceptable or this is unacceptable. However, if I were to go on just the standard on which I have been rating the segmentations, you need multiple metrics to gauge the performance.
Great, thanks.
That's great. Jake?
Yep, thanks. Really good presentation, Keaton. I just had a couple of questions. So with you mentioned that the distance metrics, they performed, distance loss functions, I should say, they performed worse than the other loss functions. I think you also mentioned that you only trained those models for 100 epochs instead of the conventional 1000. Do you think it would have made a difference if you trained them for the full 1000 rather than shortening it to the 100?
That is certainly possible. What I did find is that I don't have the graphs here, but just actually viewing the validation accuracy, it did appear to taper off and plateau around, I guess, the 80 epoch mark. Whether or not that actually stays consistent as an epochs, it's unlikely. But yes, I would have to go through and verify to see if that is the case. What I did discover is I did break down the performance of the HD binary and the DICE HD onto each of the contour sequences. So I have them here. What I found is that they actually performed very well on the cardiac silhouette. So the ascending, arch, and descending quite tanked the evaluation metrics because I averaged over all 4 sequences. So the cardiac silhouette is obviously a lot easier to segment compared to the ascending aorta. You can just see by looking at that. But that does obviously mean that perhaps the model is capable of approximating those segmentations, but they might need more time. So yes, I probably will explore that now. Thank you for bringing that up. It's a good point.
Cool. Yeah, thanks. I do have another one as well. You mentioned that the model was overestimating the end slices in some cases or underestimating the end slices in some cases. You also, I'm just wondering if that's not as big a problem as you think, because when you did the Interobserver study, it turned out that your model was at least approximately 50% of the time was as good as that, as the same observer doing it again. And if you had more data from a second observer or even more, I think you'd probably find that that's not as big a problem as you think it is. What do you think?
No, I agree. So that was one of the points I wanted to investigate was whether a different observer, how they would compare to the same observer. So the inter-observer variability study as opposed to just the intra. You're absolutely right. You can see it already on the 7 slices I have here. The performance is more or less clinically viable. It's just these 2 here which are reduced scores. So chances are the places where the segmentation metrics are being dropped is in those endpoints. So like you said, different clinicians might have different standards on which they assess that. They might all still be relatively clinically viable. So it might be worthwhile, just evaluating the metrics on the slices which are consistent on both. But also, like I said, it's pretty easy to go through and delete these or add them afterwards. So majority of the scan could still be contoured automatically.
Yeah. Just out of interest, with the intra-observer cases, did you notice any where, like in one of the segmentations, those end slices were segmented, but in another one they weren't segmented? So like where the same observer hadn't segmented those end slices, do you know what I mean?
Yeah, no, I know exactly what you mean. I didn't actually print those out, so that's something I could investigate. To see whether it was dropping on the slices.
Yeah, that's interesting to see.
Or if the observer was, I guess, stopping too early or too late. Yeah, I suspect because the scores are so similar, that could definitely be a source of error. That could be where majority of the error comes from.
Yeah, for sure. I think just based on the scores, you could probably say that there was definitely some slices, that they segmented in one of their observed segmentations, but not another one. So that's all from me. Thanks, Keaton.
Okay, thanks very much, Jake. Any other questions?
Mubashir has something in the chat.
Yeah.
Okay. So, Mubashir, can you please repeat your question? Because I cannot see the chat here.
His laptop is broken, so you have to read that.
Okay. Okay. So, Keaton, can you please see this?
Yeah. I'm reading the question. I'll just read it out to everyone. Have I considered tailoring the UNet model to improve the performance? From the images, it looks that the segmented area is very small compared to the size of the image. In two parts, I'll answer that. So the first is the cropping of the images. I'm not sure if it showed up. I'm not sure if I had an image of this anywhere. Oh, yeah, you can see this here. Majority of the image is empty space, as you can see here. So that would exacerbate the class imbalance problem. And then UNet does go through to crop all of these to the pixel borders, which do include intensity values. So that would in turn reduce much of the class imbalance problem and make the segmentations not as small. In terms of actually catering the NN UNet model to improve the performance, the only tinkering I did thus far with the model was in subbing out those lock factors. I'd be interested to see if there was a way for me to, I guess, adapt the number of layers or the filters, etc., to see if I could address that class imbalance problem. I haven't actually looked into that directly, so any insights you have on that you could provide me later, I'd be really appreciative of.
That's great. Thanks, Keaton. Any other questions from Keaton? Oh, good. Questions. That's really interesting research, Keaton. Especially it would be really useful for remote area which you don't have access to a specialist immediately. That would be really great advantage for those areas. And as you mentioned, I really need to appreciate the impact of machine learning cluster to the quality of our research, and we can see in the future even more advanced techniques in machine learning using you guys as the collaborators together and helping each other. Okay. Thanks very much, Keaton.
Thank you very much.
I need to stop recording.